Hello, everyone, and welcome to our SIG meeting today. It was so great to see so many of you at the conference. It was a great conference. Really, I thought we had a great, lots of good learning opportunities and chances to mingle and see each other, and just was magnificent. Um, And just a reminder that we are, I think the nominations are still open for the co-chair and secretary. So if you're interested, please fill those out. It's been sent on the listserv. If you can't find it, just shoot me an email. That's something that you're interested in. It's going to be great. I'm going to stay on as co-chair for one more year for some continuity, and then uh, we'll rotate off next year. So join me, and we'll build on the fun that we've been having over the last year. So today we have a great guest speaker. Whenever we had talked about different content that we wanted. Some of our members are really interested in learning more about leadership and kind of the roles of leadership uh, in collaborative care and integrated care. And since CFHA has the great knowledge and expertise of Dr. Sandy Blount, he was really very he was willing to come and talk to us. We'll say that I am freshly alumni of his training class. Me and Jen Thomas, who's usually here. I don't see her name on here. She may not have been able to make it today. Um, and it's been a really great experience. It helps really kind of support learning in this area. So we really are happy that he's able to come and talk to us. And so I will pass it along to you, Dr. Blount.
Well, thank you. And I'm actually honored to be here and excited. I like to talk about leadership. I like to talk about the course that we've been doing now as part of CFHA programming since January of 2021. We are going to start our 10th cohort in January, and right now we're doing 2 cohorts a year, January and September, starting. We have 10 people in a cohort. We went up and down for a while and settled on 10 because it worked with the curriculum, with the number of folks that needed to get to have a session just for themselves in the leadership discussion. I am qualified to teach this course because I have been in some kind of leadership position in a mental health or healthcare setting since 1977. And that has given me time to make every damn mistake you can possibly make. And so it's been a chance for me essentially to build the course that I wish I had way back in earlier times. But I have a set of slides here, and I'm going to talk you through them and use them as a structure for what I say. One of the problems with slides is it tends to make folks passive, the audience. Gradually, you'll notice your jaw going slack and your eyes at about half-mast. And so I want to give you a poke before we start, which is interrupt anytime. This is not a talk at the end show. This is a let's just talk through it the best we can. And if I have to hurry up at some point, or I would rather it felt at least a bit interactive rather than you felt like you just got talked at for 40 minutes or so. So here comes the share the screen. I'm going to optimize it for things I'm not going to need here. And now we're going to do this. And wait a minute, go away. Come on back. There you go. All right. So this is close to, it's an edited version of the presentation I gave just now at CFHA. The course was created because it was needed. I've never instituted something where as soon as people hear that it's there, they go, oh my God, is that something that's needed? Then that's been the general response. And it comes because as integrated care grows in whatever model it's being implemented at, the people who got there first find themselves with company. And so the first person who came in and was there for a couple of years now has 2 or 3 or more other behavioral health clinicians as colleagues. And in fact, it's perfectly reasonable to expect that the setting also may have merged. There's been a lot of mergers. And so they get, I want to say promoted. Sometimes it seems more like everyone else stepped back at the right time, but they become the leader. And most of these people had gotten to be pretty good clinicians. I want to say very good clinicians in most cases. But they have no training in general in leadership or management. And as equally important is the organization has no training in what to do with a management person for behavioral health. And so the head of nursing is not used to having a person who's responsible. The medical director is not used to having such a person. People higher up are not used to having such a person. And so it means that they don't tend to make space. And so as you're going to see, that it's generally on the manager to carve space. So this is what people need to become better managers, and mostly they haven't been trained in it. They need to learn how to exercise authority, think systemically in making decisions. Now you're working through people. You're not just the one who goes and does it. You have manage individual subordinates' performance. Ooh, that's tough stuff sometimes. And often we're really scared of it. We don't know how to build engagement with people that we're starting to manage. How to exercise influence, how to establish credibility, build commitment on the team, lead a meeting, how to communicate effectively, and how to listen to subordinates. And if you look at this list, what you'll discover is that each of the elements is a piece of the one above it. So 7 is a basic in order to do 6 is basic in order to do 5, all the way up. But there are surprises for people. And when I talked about there not being a place for you, this is how it tends to um, work out. And in fact, this is the most common report of people at the start of the course. Why don't they do what I ask them to do? I mean, I have these subordinates. They know I'm the manager. They know they report to me. And I say, we're going to do it this way after consideration. And so often they just ignore me. They just go on. What the manager has multiple functions. One of them is supporting the subordinates, and one of them is guiding the subordinates. And the subordinates, particularly when the position first is created, the subordinates tend to lean strongly toward the supporting role of management. Help me when I need you. Try and take some of this administrative system stuff off my back. Keep it to an absolute minimum. I try to minimize anything that gets in the way of my autonomy. I am a clinician. I know how to do this work. And so you don't really need to spend your valuable time trying to guide me. I've got it.
Looks like there might be a question.
Oh, I can't.
Kareem, I've just got a
Yes,
hand up.
I don't
Yeah.
see the hand. I'm sorry. Let me go to chat and
Okay.
participants maybe and put those on.
Hello. I just wanted to just interject. I recently had a meeting with my primary care director, our medical director, and during the meeting she had mentioned about how she didn't even think we needed a integrated, or we didn't need a behavioral health director. So not only is there sometimes not space for behavioral health directors or managers in primary care behavioral health settings, some of the medical directors may not even believe in the role or the position. It was such an interesting comment, and she just pretty much came out with saying how we have too many directors. We don't need a behavioral health director. I'm thinking that's my job. I was a
Yeah.
BHC for about 5-6 years before being thrown into a director position because we had someone who resigned with little training. And not only that, there may be people who don't even believe in the role, which is interesting. So
Yes,
um,
I think that's basic testimonial to what I'm saying. And your support in the organization will be to some degree reflective of the organization's support of integration generally, as well as the elements that I've been talking about subordinates not expecting to need guidance. And then the people above you, and here we get right into what you're talking about, superiors want new managers to be accountable for everything in your unit, that you communicate to the people in your unit. We don't have to do that. You are the one who delivers on the mission and on the goals of upper management. And so as long as we don't have problems from the people that you supervise or that that report to you, you're okay. But then there's the whole issue of other leaders who say, I'm not sure I need anybody gradually pushing into my space. And in early implementations of integration, it's not uncommon for physicians particularly, but other staff as well, to feel like we got another person here, we have to worry about them, they're going to take time, they're pushing into my space. That's very common. And the conclusion is that part of your job is to consciously work to reconcile the expectations of others and their roles, so that you need to help create the role even though they created it. And while you have a job description, I'm assuming, very often the person in the role wrote the job description, which gave you some flexibility on the one hand, but on the other hand, nobody else had a part of it, so nobody else was particularly committed to it. And so the fact that you have a job description that says you should do this or that and the other, and no one pays attention to it, is not unusual. Other thing that we work on in the course is both sides of a dichotomy between management and leadership. Management is distinct in the sense that management is a role. It is has to do with the organizational structure. Leadership is a set of abilities to influence other people, and to the degree that leadership corresponds with some place in the hierarchy, it can be a function of the hierarchy. But we all know people who are leaders that have no special role. They're just, the internet now has this role called influencer, which always makes me laugh. How do you know you're an influencer? That's not up to you. That's up to somebody else. But the idea that leadership is about being able to influence, and it takes longer. It is a long-term kind of function as opposed to management. So this list is pretty clear, I think, but leadership produces outcomes. I mean, management produces outcomes. Leadership grows capacity. Management solves problem. Leadership fosters innovation. You're individual with management. People report to you. In leadership, you're building a group, building a team. Information is the basic currency in management. Meaning is the currency in leadership. So one is steering the ship, the other is charting the course. I'm not going to go talk about all of them. For those of you who are interested in systems thinking and in levels of learning, it's reasonable to say that management is a first-order learning phenomenon. Leadership is a second-order learning. In other words, management is learning what to do within the present understanding of relationship. Leadership is, in second-order learning, able to engender different understandings, different perceptions, both for the leader and for the people that they're working with. So in the course, we have a bunch of management kinds of attention that are built on what is ultimately an approach to leadership. And we use appreciative inquiry, which is a recognized and very well recognized or supported approach to organizations. It sounds, when you hear it in practice, it sounds like solution-focused approaches to organizations. And we start with about 5 sessions working up to a foundation in leadership understanding. But as we go on with management kinds of meetings, we do it from a appreciative inquiry foundation, that it becomes part of how we understand what we're talking about. And when we're doing things like selecting and onboarding clinicians, teaching primary care and behavioral health generalism, personnel evaluation and growth-based leadership, using data to assess and tell a story, open notes and patient-centered thinking, registries and population health, and team-based telemedicine. Oh, sorry. The other important piece of the course is that each of the participants has a peer consultation in a whole meeting focused on their organization. And so there'll be, out of the 23 meetings that go really around the year, once we have 1 or 2 holidays, we're pretty much around the year, because we meet every 2 weeks. That's why we have 10 people, because that's what makes it fit with the 23 meetings that we have. The consultation is focused on a problem. You can see at the bottom there is the template that we ask for each person to write up, and that this is all in less than a page. This is just to orient us to what you're going to tell us, and give us a chance ahead of time to think about what might be useful way of approaching. So the person says a bit about their background and of the setting that they're in, what their setting is, what the problem to be addressed is, defined completely by the participant, what the context of the problem is, who are the players. In other words, if you were going to have a meeting to solve this problem, who would have to be there? And so usually it's 4 or 5 people up, and usually it's up and down the hierarchy. And how would I know if this is helpful? Because if you have a clear idea of what would be an outcome that would make this better, it really helps everybody else who's involved focus on what could be useful. And so then we have this process where most of the people in the cohort are involved. We act out, if you will, enact is a better word, I guess, the meeting where this problem is addressed. And the players are played by other members of the cohort. And so if we have 5 players listed, we will assign different members of the cohort to be those roles. And then we ask the person who's getting the consultation to go around and tell each person what their role, what the person they represent would have as a perspective in the meeting. And when the perspective that the consultee is enunciated pretty carefully, it gets made more human by having somebody play it. And the people in the course have a lot of experience in organizations, and so they often can play these roles with a great deal of accuracy and thought. That it is really common for the person who's consulting to say, "Oh my gosh, you sound just like her." And then I lead a meeting to address the problem And mostly the goal for me is that the participant, the consultee, have an opportunity to be aware of or to try out different perspectives on the situation, to reframe, to redefine the situation, and therefore to be aware of more options than they are. We don't try and come up with the best option. We don't try and impose a pathway on anybody. We're just trying to give them a chance to get out of the sort of stuck place that they bring us. And so when we're saying exactly what we're going to do in this meeting, I often will nudge the definition toward being a solvable problem. It is much better, if you can, to define a solvable problem, because once you begin to solve things, you discover that you can keep going, that it breaks through the sense of this is a cul-de-sac. We just can't get out of here. Try and humanize the players, and that's usually very easy. That the COO who has not been supportive on hiring new people because they are they just say no, turns out to have a connection to the mission, a commitment to keeping the lights on. Once these people are humanized, it becomes easier for our participant to find common cause with them. Sometimes we have to change the level of analysis to go up a bit more general, or to go down even more specifically. That there can be small changes that could make big differences that the person may not know about. I try and question assumptions, and often these assumptions are implicit. So who says it has to be this way? It's something that the person just assumes. Well, of course it has to be this way. We look for unseen options. Once in a while, there'll be a fact or a study that I know about that I can kind of throw in. But I don't tend to say, did you know? I tend to say, in a lot of situations, people have found so-and-so, or there was a study by somebody that said that, in fact, it goes differently than we've been talking about. And then as you lead a meeting, you are always in the role, if you're the leader, of reflecting. And that role of, when someone offers an idea that seems to have a real power in changing, or potential to change perspectives, underlining that through your reflection, or through saying, could you tell me a little bit more about that? So that the things that seem to open up options get highlighted as we go through the meeting. And so everyone has one of those. The reports generally are, and in our presentation, Jen Thomas talked about her meeting and the change of perspective that was involved for her, and the fact that her change of perspective did not come from anybody telling her to think differently. It just, as she heard the possibilities and the options, she decided something different than she would have decided otherwise. So this is from a different person who took the course, from cohort 1. that he wanted to say that it was comforting to find out that the problems that you were having as a leader turned out to be much more general than you thought. He said he always felt like he was just the one who couldn't get it done. It depersonalizes the struggle and makes it part of a larger pattern that helps people feel like they can go forward with some energy, because it turns out to be a common pattern that often gets better. A lot of times we are able to show the folks that not only is this general, but that they, as they hear other people and other people's settings, almost always they hear something that they have gotten farther than somebody else in some element. And so they begin to have a more substantive sense of themselves and the success already that they have had. And he said, but there isn't a magic bullet, and feeling settled about that it's going to be a process. It's going to take a while. That there's a developmental trajectory in implementation and in knowledge and experience around leadership. And that there are pros and cons. That pros are that he has relationships with clinicians. Cons are that you, over time, the longer you're in an administrative position, if you're not doing clinical work, you lose some of your street cred on that front. But mostly it's about being one of them or being of another sort of role, and that's a delicate balance. Their setting is in year 11 of integration, and he felt like recently the concept was finally fully embraced. Year 11, fully embraced. That having that sense of how far we've come, and that it's going to take a good deal of time. And the good clinician does not equate with a good administrator. And so it's a different set of skills. And the more he got a sense of what those set of skills were, the more satisfying it felt to be in his position. We have an evaluation process. We use retrospective pretest methodology. And I give you the link here, is to a paper on the validity of retrospective pretest methodology. It's very simple. You have a set of questions about the person's experience of their own competencies. And you ask them at the end of the experience, on a scale of 10, where were you in this competency when we started, and where do you feel you are now? And what's been shown is that any one person's assessment is not valid, not necessarily invalid, but cannot be expected to be valid. But a group can. And that was a big surprise to me when I read that literature. I thought, okay, this is what we want. So we asked people who'd taken the course how they felt on their the competencies that we developed as a leadership competencies. I've been a part in very big processes to identify the competencies of for behavioral health clinicians. One of them was in Colorado, and we must have had 500 people who were involved in one way or another over the course of the process. And we came up with a list that looked really just like it would have looked if you had sat down and written them down yourself in an afternoon. So
I think Patty has a question.
yes, Patty.
Um, you might have said this, but when you do the pre-course evaluation, self-evaluation of their competencies, do you do it before the course or
No,
after the course?
after the course.
Okay.
The reason is when people rate themselves before they have the training experience, they usually misjudge what there is to be known. And so they think of themselves as more competent than they think of themselves after the experience. In other words, so the experience doesn't get fairly measured. Whereas if you say afterwards, before I got here, I think I was, a 4 on team building, and now I think I'm a 6. And you have a group of people that turns out to have validity. That makes sense?
Yes, it does.
Okay. So, and this is so this is the summary of the people from multiple cohorts, and and my friend Matt Martin at ASU, who's a stats wizard, did the significance runs for us, and they turn out to have significance, to be statistically significant. So in the summary, just on its own, behavioral health integration is a fulcrum. I use the word fulcrum for change in an organization and a clinical organization. It often is the way you start getting to real team care. It often is the way that you get to start with the idea of adding a different expertise set to the team. Before integration, there's one expertise set. It's a medical expertise set, and there are different levels of training in that set of expertise on the team. When you secondly have behavioral health there, now you have a new expertise set have someone on the team with more expertise in this limited area than the physician or the PCP. And often that begins the experience of being a real team. I often call what's there before you have a second expertise set a squad, because it's got a leader and everybody has a role in the squad, but it becomes a team when you have other people with roles that are just as crucial. And then once you get that comfortable with that, then the next expertise set that can be added sometimes is that of the patient. And now that's a new person on the team. And so just going to integration is going to change the practice throughout the primary care setting. And then even the people that we get in the course are skilled problem solvers, but they're skilled at interacting with other people, but not, those are only foundational skills, and they need practice and time to develop not only management kinds of skills, but leadership kinds of skills. The team has, the course has a lot of bits of wisdom about successful integrated care sites. There's a good deal of exchange between members of the cohort on, some will say, I don't know how to handle this list or this screening action. And somebody else say, oh yeah, well, we're doing that. It's working pretty well. So there's a lot of details that are helpfully there, even when we don't have a whole setting on talking about that detail. But the job of the course is to help people over time get a broader understanding of what to expect from their roles, to recognize the impact they're already having and to gain systemic vision of building influence and relationship. Jeff, who was the person who wrote the 2 previous slides, said that it made him comfortable with the learning curve that he was still on in the course, not just that he learned everything that there is to know. So I have stopped sharing my screen. Hey, Ron. So let me see what y'all have to ask or say or discussion. Let me go look at the chat, see what's up there. Okay.
One of the thoughts I had as you were talking is that at least from my perspective and my experience, I feel like that this group has some similarities in the course that we did, in that we, everyone here is trying to or has developing and building collaborative care at their and in their in different types of integrated behavioral health in their setting. And we learn a lot from each other and help support and commiserate and share the struggles that we're having. And so I have really enjoyed being part of this group for that reason, and I had similar feelings and experiences that we had in the training.
Right. There's a lot of virtual hand holding.
Yes.
Gretchen, you have your hand up.
Hi, Sandy. Yeah, thanks for the conversation. I'm part of a new healthcare system that is in the process of just getting started with collaborative care and looking at hiring a director, and then like 5 clinicians. Well, 4 actually. We have one that's kind of the pilot person already on board. Curious about your thoughts about the director position, taking a course like this right away versus after they have kind of got their team set up and have gotten their feet wet a little bit, or other kind of resources that you would recommend for that person. I'm kind of in an advisory capacity, so I can provide them with, like some ideas of resources to get this person up and running.
Well, if it's possible, I think taking the course early is a good idea, because it's early that people are asking the question about how come they don't do what I say, that all of those things around the role are most intense, and so you have more flexibility early on. So I would suggest, if it's possible, to do it earlier rather than later.
Mm-hmm. Okay.
And Laura, go ahead. I can't hear you.
Still muted.
My poor phone. Sorry, my camera went out and then I had to get on my phone. I really liked how you talked about the language of the difference between a manager and a leader. And I would say role confusion is a huge challenge for organizations as well as for individuals in organizations. The other ones I would add to that list are like the difference between teacher and mentor and coach, and like the layers of that. Do you have any additional guidance for how we can help ourselves and how we can help our organizations in clarifying roles and preventing role confusion, particularly in integrated teams where we may have managers and leaders, but then also all these other kind of levels of roles that there may be very different interpretations of up and down the scale?
Well, the first thing that comes. I'm echoing. Okay, that's good. So the first thing that comes to mind is, to the degree that people have a sense and toleration or tolerance for the fact that we're building the plane while we're flying it, can be very helpful. Again, if everybody reads the job descriptions and says, there it is, that's what you have to do, it's going to be hard because it's not going to be nicely crafted. And even when it's nicely crafted, there are going to be a lot of places where you have to use your judgment. One of the things we talk about in the course a lot is how do you influence people that do not report to you? That the more you're at it, the more ultimately you would like to be influencing the CEO and the COO and the CMO and the people in your setting. And you don't have first of all, you may not be at those meetings. I would say 2/3 of the people in the course are not at the top level meetings in their organization. And the more mature organizations sometimes have chief behavioral health officer who is at those meetings, but those tend not to be anything like how they've started out. But we talk about narrative. We talk about getting from digital, we had 35 warm handoffs this month. And if you send that to up the line, and you may very well do it, it could be a good idea to do it. And certainly you consume it within your own group, whether you think 35 is enough or we'd like to have more. But if you send the number without a story, it's not going to be very effective. Nobody else knows how hard won those numbers are. And so they get less and less impactful as you go up. That's why we had the meeting on making data tell a story. And so you want to add the story of one of those people so that people get a sense of the human experience that each of those numbers represent. And with a warm handoff, it is immediate service as opposed to 3 weeks on a waiting list and then a high dropout and a high no-show rate, because the more your waiting list, the more your no-show rate. And the sense of each of these things represents something that may make the life, the difference in a person's life, that they got response today, they got response for what they came for and what they're defining their problem, not just something that we did, and that they have an engagement that may or may not go on to other meetings. Does that make sense?
That does make sense. I think one of the challenges can be if those stories don't matter to upper leadership, or what do we do kind of with that piece of, like, I feel very fortunate that I do have upper leadership that are very supportive, but I've worked with others who are like, that doesn't matter to our upper leadership or whatnot. What are your perspectives on when you decide it's time to abandon ship versus, hey, give that 11 years, give
Jan
that.
can tell you that story. I think that in general, my experience has been it matters more than you think. And so for somebody to have sat in a meeting and say, we really, really, really need this, and upper leadership to say, nah, I don't think we can do it. We'd love to do it, honestly, but I don't think we can do it, makes it feel like they're absolutely rigid. They can't get there. But often if you highlight what upper leadership is doing that contributes to the effort that you support, you discover that they define themselves as more on the team, and they're likely to act more on the team, and that people have a real response to human response to a story. I would do a newsletter. what I did was I did a newsletter, and it was just internal, wasn't for the community at all. And I reported about quarterly on the numbers back in the day when it was just me, and how many people I saw and warm handoffs and that kind of thing. But I would always include one case example. And for instance, one time I had a case with somebody with IBS, and we worked together very well. And she got better, and she got better very quickly. And she moved to be more adherent to the medical recommendation for what she should do. And when I put that story in our little internal newsletter, the next 2 weeks, I got 3 more IBS referrals. That if I had gone around, I did go around and say, I do physical things. If you've got a physical problem or a person has a physical problem that relates to adherence or depression or stress, wind me in. And they didn't do it. But when I told them the story of it going well, that suddenly they did.
I think that's a really helpful point too, about the narrative and the story being relevant to that audience. And sometimes
Yes.
I think that's where we can get disconnected. What is the story that matters to one versus another? I think that's a great example with the IBS.
Yeah. And I think one of the things to just kind of add to what Sandy was saying is one of the great things that we did in that class, the perspective taking, and having people role play those specific individuals and really having to look at things from their perspective kind of helps you model that story. It's still the same story, but you're telling the story with their perspective in mind rather than, what we want to say, what we think is important. So that's really kind of helpful.
And the feedback has been from members or participants that being an actor in these consultations is almost as useful as being consulted to. And so and then if they have 10 of these to go through over the course of 11 months, they have time to learn, they have time to internalize. Remember, leadership is development that is akin to changing perspective, changing perception, changing being able to spot options. That's something that you don't do after some lecture somewhere.
Got a couple more minutes. Any other burning questions while we have such a great expertise on the call?
I have another question. I'm curious about the Sandy, you were saying earlier that there are some organizations that have evolved over time to have a CBHO. Curious if you have any kind of insights into how those organizations evolved into that structure, or like what structures you would recommend, and any tips for how to advocate for those structures.
I don't know. In each of these cases, they are places that have had integrated care for a long time. It's wherever you have somebody or some organization where they feel like this is the new thing, I think it would be hard to do that. I wouldn't set that as a goal. I think position title as a goal can get you sidetracked sometimes as a leader. And so I found also that I could communicate directly with people at the top of my organization if I just went ahead and acted like I had a right to do it, as opposed to if I was invited to the meeting. And I certainly went through that time where I felt like there was a core group that sat with the chair and I ought to be there. And of course, after I left, the next person who took my place was there. That happens a lot in organizations. But mostly I was too timid early on to just say, grab the chair or grab somebody else that's higher up and say, can you give me half hour? And they always would. And it was very helpful.
Hello? Hello? I don't know how to raise my hands. Can you hear me? You can hear me?
Yes.
Oh, can I just say something really quick? Hello, everyone. This is my first time joining this meeting. And I joined this meeting from the conference that I was in Phoenix. But my name is Akia Fagans. I'm actually a Chief Behavioral Health Officer. So I just wanted to kind of answer her question a little bit because that is my position here at my agency located in Philadelphia. So my position evolved. And how it evolved is that as a health center, we always offer specialty care. So what I mean by that is that we always had an outpatient drug and alcohol program and an outpatient mental health clinic. And then we added integrated care into our health clinic. So we kind of did it the opposite way. So as we kept adding more and more programs, my title kept changing. So I was over outpatient mental health, then I took over drug and alcohol. Then as we brought on our BHCs and integrated those into our clinics, I then took that over with MAT and some other stuff. So my position migrated to Chief Behavioral Health Officer because I do more than just the integrated piece in the clinics. I also run specialty clinics for our agency. So I don't know if that answers her question a little bit, but it was a position that evolved into that as we added on more pieces.
Great.
Thank you and welcome. We're glad to have you. Well, it's right at 2:00. And I know everybody probably has things scheduled and has to hop off, but thank you so much, Sandy. This was really helpful and good conversations. So
I'm glad to do
have you
it.
back.
Appreciate it, everybody.